I'm your host, Neal Howard, here on Health Professional Radio. Thank you so much for tuning into the program today. You know, there are an estimated 13 million people with latent tuberculosis infection, or LTBI, right here in the United States. Our guest today is Dr. Reichman. He's professor of epidemiology at Rutgers School of Public Health, and he's joining us here on the program to talk about a recently published article in the New England Journal of Medicine that talks about the need for renewed action to fight this war against TB. Welcome to the program, Dr. Reichman.
Thank you very much. Glad to be here.
Right. After just a bit of background about yourself, talk about this latent tuberculosis.
Okay, well, tuberculosis, believe it or not, is the biggest killer of any single infection in the world. And it also has a very high prevalence. It's a two-form disease, so you can be sick with TB, where you have TB affecting the lungs or other organs, and you can spread to other people. Or you can have the form where you have caught the bug, but your body defenses have defended against it, and that's called latent tuberculosis infection. Now, a third of the world's population, believe it or not, do have, by estimates, latent tuberculosis infection, and that includes 13 million Americans.
Does that mean that anytime you're tested, you're going to show up as having the disease, even though you're not symptomatic and you're not able to pass it to people, even though your defenses have defended against it, you still have it, or is it a done deal?
Well, there's two kinds of tests. There's tests that actually test for being sick with the disease, and that's looking and finding the bugs in the sputum or other body fluids. Then there are other tests that just tell if you have latent TB infection, and that includes the interferon gamma release assay. These are blood tests, or the old, but still unfortunately widely used, skin test.
Okay, that's what I was talking about. That I guess the TB Tine test is what it was called, or what it is called, right? Right.
Well, actually, the TB Tine test was very old, and I don't think that's even licensed or around anymore.
Oh, okay.
The skin test now, they take antigens taken from the bugs and inject it under the skin, and then the patient is supposed to come back after 24 or 48 hours to have it read. And if he comes back, very often he doesn't come back, it is read. It's a very subjective test, and the subjectivity is a problem, and it's a very crude test. You get a lot of positive reactions in people who aren't infected with TB.
Oh. Well, before we get into the study, how is TB transmitted for such a huge part of the population to have latent tuberculosis?
TB is only spread from somebody who's sick with tuberculosis of the lungs, who is coughing, and he aerosolizes the organisms. Just if you can picture a person, the spray that a cough sprays, and people who share the air for a considerable length of time, usually the household contacts, or sometimes the work contacts, or people who are living with him in the jail or the hospital, they catch the disease, they catch the bug, and immediately their body defenses contain it, so that person has latent tuberculosis infection. Since TB is so widely distributed, and since countries outside the United States, third world countries, Asia, Africa, for instance, Central Asia, have huge amounts of TB, and therefore they infect a lot of people, and so they have a huge amount of latent tuberculosis infection.
With all of this transmission, how does our immune system, are we evolving? Are we becoming less and less susceptible to it? Is this number of 13 million just in the United States, is it going to decrease, or will we see an increase prompting, more awareness?
The immune system is not really evolving, but the immune system protects against infections with all sorts of organisms, and we're very lucky that it infects against TB. But if there's something interferes with the body's response, for instance, stress, or someone, for instance, who has latent TB infection, and he goes to the rheumatologist and he's treated with one of the infliximab or Humulin or something like that, which if you notice the advertisements for those drugs, they always say test for TB ahead of time. And that's because these bugs, by interfering with the immune system, which causes the rheumatoid arthritis or the psoriasis, it also interferes with the immune system that protects against TB. The same thing with steroids. The same thing with diabetes, and is a big unrecognized risk factor for getting active TB when you have latent TB. So all of these things are going on, and I think the perspective in the New England Journal that you were talking about called attention to the fact that this has been going on for a long time, and it's time to take action against this.
Well, let's talk about this action. What do you think are the main takeaways from this study that was published in the New England Journal of Medicine?
Well, I think first the fact that it was published is remarkable because it's calling attention to a prevalent problem that most people know is there, but people don't care about. I mean, as I said before, this is the largest killer of any single infectious disease, and yet no one gets excited about it. Every year, 1.8 million people die of tuberculosis, which is preventable and curable. Now, TB has an image problem because if we said, oh my God, flu has done this, or Ebola, we would do something about it, or even AIDS. But TB, they have it. Well, now, with TB, we have new technology to detect improved technology to detect the infection, and a fantastic new regimen of drugs, which for 12 doses of a drug regimen will keep someone from getting active TB. And that is remarkable.
How are they going to basically eliminate TB? That's what we're trying to go for, isn't it?
Right. Well, if you can detect that someone has latent tuberculosis infection, and you can start, say, just with contacts of active cases of tuberculosis, or healthcare workers, or prisoners, or people who live in congregate settings where there's a lot of TB, or even foreign-born people, because these are all risk groups in the United States. And you say, okay, we will use the blood test, the interferon gamma release assay, to detect whether they're infected with the tubercle bacillus, and then we treat them with 12 doses once a week, 12 doses of medication. They're out of the risk pool. They're not a problem anymore. And so the technology exists. All we need is the will to do this, and I think this is what Bayer and Castro in their perspective in the New England Journal were talking about. They said, let's get on and do this.
With this new technology, is there still an age factor, or are there liver factors involved with some of the newest treatments and developments in TB treatment?
Well, used to be we'd skin test someone, they'd go home. These are people high at risk. They'd go home, come back 48 hours later if they came back. We'd feel a bump on the skin, which is sort of paradoxical in an era of high-tech medicine. We're diagnosing TB by feeling a bump on the skin and saying, gee, you have latent tuberculosis infection. We'll treat you with a drug that you take once a day for a year called isoniazid, which has liver toxicity and makes people feel lousy when they take it. And to take a drug when you're not sick for a year is also a big problem, getting people to do that. So for all of the, and the other thing is this, think of the skin test, and I think the skin test is the most widely used diagnostic test in the world still. But then you think of quality control. You know, laboratories, my laboratorian friends tell me that they get quality control to death for everything they do. Mm-hmm. And then you think of the skin test, where you skin test someone, somebody reads it, and puts you on a medicine that has side effects. Has that nurse who's been doing the skin test, or the medical student, or even the doctor, ever been quality controlled? I don't know that anyone ever does that. And so they assume that these results are correct. Meanwhile, if you take the test and you use a test like quantiferin plus, which tells you the immune system is working against the tuberculosis, the doctor's not doing that, or the nurse. They're just drawing the blood. It's done in a laboratory. Laboratory is quality control to death, as we said. So at least you can trust the results.
Interesting information, especially for someone who has such old information about tuberculosis. I appreciate you coming in and giving us this information.
Well, Neal, if I can just add, Neal, don't feel bad about holding old information. That's one of the problems. People assume, TB is an old disease. We've had it under control for years. That's what the assumption is. And even if you go to a reporter in and reporting on some new acute health problem, TB is not a problem but it is. It affects this many people, and it's preventable and curable, which is a paradox.
Well, I'm hoping you'll come back and give us some more updates as technology advances and we move to eliminate TB altogether. It's been a pleasure, Dr. Reichman. Thank you so much.
Okay, bye-bye.
I'm your host, Neal Howard. Transcripts and audio of the program are available at hpr.fm. Be sure and visit our affiliates page when you visit us at healthprofessionalradio.com.au and also hpr.fm. Sign up for this podcast on iTunes, download and listen in at SoundCloud. And thank you very much for listening in to Health Professional Radio.